can now start. Welcome everybody to this new episode of the Info Masterclasses, this is actually the first of the two-part series focusing on neurofibromas, on plexiform neurofibromas. And I want to, before I give the floor to everybody for the actual masterclass, I need to give you instructions for the Q&A. You will unfortunately not be able to interact directly with the lecturers after the talks, but you can ask your questions through the Q&A box or in the chat box, and I will be moderating the Q&A session afterwards. Now I'd like to pass the floor on to Rianne Oostenrijk, who is the initiator of this two-part series on plexiform neurofibromas, who will introduce you to today's lecturers. Thank you.
Thank you, Marco, and good afternoon or good morning, wherever you are joining. Thank you for joining us today on this webinar on plexiform neurofibromas. And today we have a combined clinical and more radiology-focused session on the plexiform neurofibromas in NF. And we have two speakers, and I'm happy to introduce them now together. First, whereafter we will start the lectures. So as the first speaker, we have Hector Salvador. He's a pediatric oncologist from the St. John de Deo Hospital in Barcelona in Spain. Thank you very much for joining us today and having your lecture here. And thereafter, we have Gregor Kasprian. He's a neuroradiologist from the Vienna General Hospital in Austria. And we are very much looking forward to the combined session today. I would like to invite Hector to start his presentation on the general aspects of the plexiform neurofibromas in NF. Thank you, Hector.
Thank you very much, Rianne and Marco, for the invitation. My talk will focus on the diagnosis and especially in the natural history of plexiform neurofibromas in patients with NF1, that is, how these tumors behave spontaneously through life without intervention and from a clinical perspective. There will be, as Rianne said, upcoming talks in the next weeks about treatment, but before we need to know the behavior of these tumors to properly understand who, when, and how we should treat them. These are my disclosure. First, allow me to make a brief note for clarification. There are several types of neurofibromas. In fact, there are several classifications, and not all authors agree on the nomenclature, which can be confusing, especially if you use all pathology or molecular or clinical or radiological criteria. The cell of origin of all neurofibromas is a Schwann cell precursor, where biallelic NF1 inactivation occurs. If this tumor cell obtains the double hit in more peripheral nerves of the skin, it will produce cutaneous neurofibromas. These neurofibromas, as you know, appear in almost all NF1 patients, although their onset is usually around adolescence, unlike the rest of neurofibromas. But if this inactivation occurs in precursor Schwann cells in deeper non-dermal nerves, they will give rise to internal neurofibromas. This double hit is thought to occur prenatal, which is why these tumors are considered congenital. And they tend to form networks along the affected nerve, giving them this typical appearance. But sometimes these neurofibromas can be unique, small, localized, and do not get this plexiform, multi-encapsulated aspect, although certainly at the clinical level, usually all of them are considered the same. And that's why, in general, all internal neurofibromas are called plexiform neurofibromas, facilitate better understanding. These internal neurofibromas are the ones we'll talk about in my presentation. And since most series do not differentiate between localized and plexiform internal neurofibromas, I will name them indistintly through the presentation or use the term PN. Sometimes intermediate neurofibromas are present. These are called diffuse neurofibromas. They are typically characterized by general involvement of the skin and subcutaneous tissue, where they thicken it. They are considered sometimes a subtype of dermal neurofibroma and are usually already present and visible from the first months of life. They only produce aesthetic deformity if the involvement is exclusively subcutaneous, although on some occasions, it can be localized internally or deeply, and even accompanied by a plexiform neurofibromas in this case. For the correct diagnosis of an internal or plexiform neurofibroma in the context of a patient with NF1, a pathology, a study, a biopsy is usually not necessary. The typical clinical and radiological signs of neurofibromas are usually enough, as Dr. Caspian will explain later. But I would like to mention that in recent years, a radiological subtype of internal neurofibroma called DNL, distinct nodular lesion, has been described. In these sequences, we can see the development of a DNL over a plexiform neurofibroma. They are well-defined lesions larger than 3 centimeters with the absence of the typical dot sign. And the clinical behavior of these neurofibromas is different from typical PNs, as they tend to appear later in life, not congenital as the PNs, and usually with a greater growth rate. In the few published reports where surgery and pathology analysis of these radiologically detected DNLs have been performed, sometimes they are plexiform, but many others, they are atypical neurofibromas, the so-called ANUPs, or might even be malignant peripheral nescious tumors, the MPNST. Therefore, you need to be very cautious on these lesions when they are detected. Another characteristic of DNLs is that sometimes don't have response to MEK inhibitors, unlike conventional plexiforms. In general, the exact knowledge of these DNLs is limited compared to the rest of neurofibromas. And I'm mentioning here, but in general, the natural history talk I'll discuss next refers especially to non-DNL neurofibromas. If we perform a whole body MRI in a group of adults with NF1, around 50 to 60% of them will have internal neurofibromas. However, fortunately, most of them will never become symptomatic and could have gone unnoticed if they had not performed such an imaging test. And what exact percentage of neurofibromas will end up causing clinical problems? Although it's quite difficult to obtain accurate numbers, it's considered that only around 20 to 30% of NF1 patients will have symptomatic or clinically detectable PNs. We know that there are a few variants of NF1 gene related to a higher or lower risk for developing PNs, but in general, for more than 90% of patients with NF1, there is a lack of evidence for a clear genotype-phenotype risk of PN development. The growth of plexiform neurofibromas is unpredictable. And what does this mean? Well, if a patient with PNs comes to your office, it's impossible to predict exactly how those particular neurofibromas will evolve in the next year or until the next visit. Although, yes, as we will see later, we know the most common trend depending on the age or the presence of symptoms, but individually, we can find tumors that grow from one year to the next, or those that are stable, or even can decrease in size spontaneously, even within the same patient. And what about the development of symptoms? Currently, our understanding of the behavior of PNs in children is more extensive than in adults. The clinical presentation in pediatrics usually follows a bimodal presentation. A good percentage develop symptoms as early as the first 2 to 3 years of age, especially those deforming head and neck neurofibromas, as well as those large limb tumors. This initial peak, there is usually a period of relative stability until puberty, where we usually see another peak in the incidence of symptomatic PNs. It's also important to mention that children with symptomatic neurofibromas also have a higher incidence of other NF1-related tumors, not just neurofibromas. And although the growth is unpredictable, in children, it's common for these tumors to keep growing continuously, even more than the child's own growth, especially in the first years of life. In adolescents, they usually continue to grow, although generally at a slower rate. There are also PNs, especially from adolescents, that do not grow anymore, and even some cases of spontaneous volume decrease. In the same cohort presented in this graph from the National Cancer Institute, they published that DNLs, the distinct nodular lesions I mentioned before have a later development, a more rapid growth than typical PNs in young patients. The largest recently published series of pediatric patients with plexiform neurofibromas is from the UK group, where they retrospectively analyzed more than 120 boys and girls with internal neurofibromas. And what they found was that more than 70% of pediatric patients with neurofibromas had symptoms related to that. The most common locations in their series was the head and neck, followed by the extremities and spinal, because location is one of the main risk factors for developing symptoms. For example, when we perform whole body MRI screening, it's very common to observe paravertebral neurofibromas, especially at the lumbosacral level or the typical diffuse enlargement of the sciatic nerves. But this will very rarely become symptomatic. And on the other hand, head and neck and extremities are the ones that have the highest risk of becoming symptomatic. What I have explained so far is the natural history of plexiform neurofibromas in pediatrics, but what about adults? Well, literature is much scarcer, much limited there, but that's why I'd like to remark on the results of this recent observational study by the Boston group, where they analyzed more than 40 adult patients with NF1 and performed serial whole body MRIs with an average difference of about 10 years between first and last scan. Analyze the data on both neurofibromas separately and for each individual. And in the per tumor analysis, they find that around 60% of neurofibromas spontaneously reduce significantly in the observational period, this 10 years difference of time, with similar results for all internal tumors, both localized and plexiforms. But only 17% of them grew significantly in the same period. They also analyzed PNs separately from the DNLs, the distinct nodular lesions, and did not observe growth difference between them, unlike what's been published in young patients. This spontaneous shrinkage of PNs contrasts widely with other series with predominantly young patients, such as the one in the National Cancer Institute group or the Hamburg cohort, where they found that more than 70% of tumors grew in a short period of time. Further analysis revealed no correlation between tumor growth and variables as sex, age, genotype, location, baseline tumor volume, or even FDG uptake at PET-CT scan. And additionally, no correlation was found between pregnancy or the use of hormone-based contraceptives and tumor growth. And when analyzing the adult data on a per patient basis, they found a couple of topics I'd like to mention. On the one hand, that those adult patients who did not initially have neurofibromas at baseline very rarely developed neurofibromas at follow-up, only 1 in 10, and was only a very small tumor. This is something already referenced before and justifies the reason that, for example, in the new European Genturi's guideline for the management of tumors in NF1 is recommended to perform a baseline whole body MRI before reaching adulthood. And in general, it's not necessary to repeat that if it was normal, since the risk of developing symptomatic plexiform neurofibromas with a normal total body MRI at that time is minimal. On the other hand, although they found that most neurofibromas reduce or stabilize, when they analyze individual by individual, they observed that 60% of adults with tumors at baseline experience growth of at least one neurofibroma over time. And this reinforces what I mentioned at the beginning about the unpredictability of the behavior of neurofibromas, because we can see in the same patient neurofibromas that shrink coexisting with others that grow. Let's take a short look at the symptoms of PNs. Referring back to the previous article by the UK group, we can see that the most frequent symptoms are disfigurement, pain, and functional impairment. Depending on the location, we can see functional symptoms such as reduced field of vision if the tumor is orbital, or bladder or gastrointestinal dysfunction in pelvic tumors, or airway obstruction in neck neurofibromas, etc. In more severe cases, it can produce symptoms that severely affect the quality of life or even the death of the patient, such as hemorrhage, can be spontaneous or post-surgical, or compression of the airways or a spinal cord. Another complication of nerve fibromas, already mentioned in other info talks, is the premalignant potential. That is the transformation to a malignant tumor of the peripheral nerve sheath, the MPNSTs. Patients with NF1 have a cumulative lifetime risk of around 10 to 15% of developing this type of sarcoma, which has a very poor prognosis. Nordic European countries have amazing population databases. Some of the most important epidemiological studies are done there. And the Denmark group published last year the nationwide study on NF1 and PNs. In their large cohort of 1,000 patients with NF1, they found that around 40% of pediatric patients and 60% of adults had PNs. And more frequent symptoms were pain, followed by disfigurement and functional impairment, with very similar incidence of symptoms between adults and children, suggesting that symptoms don't usually improve when reaching the adulthood. Another interesting finding in this cohort is that more than 30% of PNs were considered inoperable. And as expected, these symptoms will negatively and significantly impact the patient's quality of life, especially in the pain, emotional, social, and functional domains, but also in their caregivers, where we can observe a high index of anxiety and depression, as long as absenteeism, a high productivity loss. But it's not only a problem for the affected patient and the relative, but also a public health issue. Patients with symptomatic plexiform neurofibromas require multiple healthcare resources. Before MEK inhibitors, it's mentioned that around 30 to 50% will require at least one surgery for their PNs in their lifetime, and not to mention the indirect costs, such as the inability of their caregivers or themselves when they reach adulthood to work properly. And now I will focus on the natural history of symptomatic PNs in children. What can we expect when these tumors become symptomatic? And while there are ongoing trials attempting to answer this question in adults, currently there is no relevant information available on adult patients yet. Therefore, I will present data on young patients, focusing in two studies, the French Cassiopeia one and the National Cancer Institute series. The NCI conducted a natural history study on a cohort of children with symptomatic or very high risk PNs. An analysis of the tumor volume of the target PN revealed that in pediatric patients, the natural history is one of the continued growth, often at a significant rate, particularly in the youngest patients below the age of 10, something also corroborated in the recently published study from CHOP from the Philadelphia group. And only a very small number of tumors showed a very slight decrease in volume. But more importantly, in addition to the tumor growth, their symptoms usually do not improve over time. On the contrary, many of them worsen or develop other symptoms over the years, especially for pain and motor and dysfunction. There was also correlation between tumor growth rate and worsening of symptoms such as pain. Today, the only curative treatment for symptomatic PNs is surgery with resection of the tumor mass, but unfortunately, in many cases, it's not possible to perform this surgery due to the characteristics of the tumor. And then in those tumors that can be removed, what happens to these symptoms? Well, to reinforce the findings of Dr. Wiedemann's group last year, the retrospective study of the French group cohort with 76 pediatric patients with inoperable symptomatic plexiform neurofibromas has also been published. And they observed that the vast majority, 90%, had more than one symptom, being the most frequent one pain, followed by deformity and motor dysfunction. 10% of them had severe symptoms associated with the tumors. The most interesting point is that in their studies, although all these patients were visited multidisciplinary in one of the NF1 expert clinics and got thorough evaluation and support with treatment, most of the symptoms did not improve over time. As you can see in this table, the pain only improved by 26% with medical support, and more than 28% worsened despite that. For the deformity, that only improved by 15%. In other words, according to this data, a high percentage of symptomatic plexiform neurofibromas will not improve just by offering symptomatic treatment, at least in young patients. And to summarize, again, the behavior of PNs is unpredictable. However, they usually have a continuous growth during childhood and young adulthood, especially the first years of life. Our current knowledge in adult tumors is very limited, but it suggested that in adults, most of these tumors will remain stable or even shrink, although some of them still have the potential to increase in volume and become symptomatic. And lastly, around 20 to 30% of NF1 patients will develop clinically detectable or symptomatic tumors. If these symptoms present during childhood, they usually will not improve over time without appropriate and specific treatment, and this can lead to a significant impact on the patient's quality of life. Thank you very much. We'll stop sharing and give the floor to Gregor.
Okay, thank you. So I think I go directly on with presenting the radiological features of plexiform neurofibroma. Let me just share my slides. I think they should be visible now. Okay. So I'm actually working not in Barcelona, I'm working in Vienna. This is the Vienna General Hospital. As a neuroradiologist, I'm in touch with plexiform neurofibroma, but the disease of NF1, as we are a center where we see quite a number of cases. And I'm always amazed how NF1 appears in different patterns and appearances throughout life. And I find it very helpful to just get an idea at which time point we can see what. We as radiologists are very frequently early on confronted with images like this one. This is a congenital pseudoarthrosis of the tibia, CPT, a mesodermal dysplasia of the tibia, which leads to this anterolateral bowing of the tibia and is the result of a focal mesenchymal defect. This is quite common in NF1, children with NF1, and that is often one of the first radiological presentations of the disorder. Here is a case from Vienna. We have also analyzed with MRI and high-resolutional ultrasound. You can see that the tibia and the bowing of the tibia is visible on with this technology as well. I just had on later on, we see more and more of the brain imaging findings, so brainstem glioma and optic pathway glioma, including a very common manifestation of NF1, the focal areas of signal intensities, or also unidentified bright objects, UBOs. Basically, they are the manifestation of myelin vacuolization, which you can find throughout the brain, but mainly focused in the area of the basal ganglia and the cerebellum. They are very common, 70%, so even more common than we see neurofibroma or, fortunately, optic pathway glioma, as you see here, an example with these thickened optic nerves in the pre-chiasmatic part here. What Hector already mentioned, and I feel that is a very important message with the disorder in general. At earlier stages of the disorder, we see these changes very frequently, at least the FASI or UBO lesions, and they decrease in frequency after 10 years significantly, whereas the atypicality of those lesions increases after this age. So this is the rate of atypical signal changes in the brain, which also take up contrast, which is always somehow a worrying sign. And you see those atypical FASI lesions which take up contrast appear rather later, and for that reason are of more concern than other lesions. At the same principle, you can also basically translate to plexiform neurofibroma, which we will see in a moment. Here is the pontine glioma, again, astrocytoma, and glioma is a very common manifestation, as you know. And again, you see the peak of these tumors is again before 10 years of age and then drastically decreasing. So it's basically, when we're talking about imaging children with NF1, we're talking really about taking care of children mainly between 2 and 12 years, also later on, of course, but this is certainly an age period where we are sort of very concerned. Scoliosis is, for instance, another issue we are confronted with. This is a very severe case of thoracic scoliosis. Most scoliosis types in NF1 we see in the lumbar spine, whereas the most frequent complications of scoliosis in NF1 we see in the thoracic spine. You see here a 3D construction based on a CT image. These types of scoliosis can be linked to, on the one hand, inferior bone quality and quantity in NF1, but also, of course, due to mesenchymal or dural ectasias we see in these children. Here you can see this complication where the cord is locally compressed due to this scoliosis. So this is a secondary problem which can be seen. This is the same patient. You can see this eccentric location of the cord with the dural ectasia here, leading also to the scalloping of the bone, deformation of the bone, and consequently scoliosis. Later on, we see the typical manifestation of the plexiform neurofibroma that can start quite early, as you heard from Hector already. And this is an MR imaging impression of these lesions. Again, MR is not the only methodology you can use to assess these tumors. Don't forget, basically, that the disorder is mostly diagnosed by clinical impression. It's no wonder plexiform neurofibroma is in common language often described as bag of worms, and that comes mainly not from the radiological but from the clinical impression. However, MRI is often not quite easily accessible, so ultrasound, particularly high-resolutional nerve ultrasound, is a technology which is easier accessible, cheaper, of course, but needs to be in the hand of an expert to really be helpful for you. This is just an example. We are more and more using this technology, particularly in children, for assessing peripheral nerve lesions. This is a 12-year-old boy with a traumatic lesion of the peroneal nerve due to playing soccer and having a knee luxation. And you can nicely see how this nerve is thickened. You can imagine that the common peroneal nerve has a diameter of 3-4 millimeters, and now if it's thickened, it's about 6 millimeters. So it's really giving you a very good and high resolution of that nerve, and you can flexibly follow the nerve around in the body. And that is particularly helpful if you look at the periphery and when you look at lesions which are more superficial. And what you see here is a cutaneous neurofibroma in a NF1 patient. You have to be aware that this is 5 millimeters, so This is really a very high resolution, and you see these very tiny nodules in the skin of the patient. Here below is the muscle. And this is, of course, nice to basically approach very superficially located lesions. Here is another example of ultrasound of the sciatic nerve. So this would be the subcutaneous tissue you can see here. These are muscles of the thigh. And below here you see these basically thickenings of the different fascicles of the sciatic nerve, representing a plexiform neurofibroma there. If you look at the same nerve in an axial view, this would be the axial view, you see again the thickening of certain fascicles within the nerve, here quite well. But if you go further up, more towards the pelvis of the patient, you will realize the resolution and the visualization of that nerve gets poorer. And that's actually the problem of peripheral nerve ultrasound. The deeper a lesion is located, the more difficult it is to access it with a proper resolution. And in those areas, it's very convenient to have MRI. This is the same patient. You can see this would be the area of the lumbar spine. There is a dural ectasia as well, but these are the lumbosacral plexus nerves, and this here is the sciatic nerve. And you can see beyond the sciatic nerve, there are multiple different plexiform neurofibroma affecting different nerves of the lumbosacral plexus and cutaneal structures as well. So the advantage of MRI is certainly the good overview over the entire anatomical region. The disadvantage is basically the image resolution locally, which is now with the good high resolutional probes. I'm talking about up to 20 megahertz probes, much better on ultrasound. So for MRI, we are using either 1.5 and 3 Tesla. I would recommend to go for 3 Tesla because it gives you more signal and more detail. What you also have to keep in mind, imaging peripheral nerves on MRI is not for everybody, and not every radiologist is equally talented to do it. You have to be very knowledgeable in coil technology, which coil to apply, which is most appropriate to basically visualize a certain anatomical region. You can collaborate with certain coil vendors, which allow you very flexible coils, and which is particularly produced for peripheral nerve imaging, or you can use the routine coils you have for musculoskeletal imaging anyways. However, it's important to note that MRI is a user-dependent technology, and not only ultrasound is dependent on the person handling the ultrasound machine, also MRI needs to be in experienced hands when it comes to imaging in the NF1. Here, the classical sequence which we use for nerve visualization, what you want is you want to see the T2 hyperintense nerve on the MRI images. The prerequisite here is that you suppress the signal you get from fat and from vessels. So you want to basically get rid of the vascular flow, but also from the fatty tissue, so that you're left with the signal of the peripheral nerves. Here you can see the different lumbar spinal nerves leaving the dural sac, which contains fluid and is bright for that reason. But also nerves have their endoneurium, which also contains a lot of fluid, and that's what we can basically see and visualize with MRI. Another technology which is recently available, recently means in the past 5 to 10 years, is a technology based on MR diffusion, which allows you to three-dimensionally visualize plexus structures. This is the same patient visualized with MR tractography. And the nice thing about MRI is also that you can basically reconstruct your images in all different planes so that you can follow nerves. This is a case of a piriformis syndrome where the sciatic nerve is split into two parts due to a muscle being located there. That would be the ultrasound image of the same patient, and you see from here to down here to the sciatic nerve, it's quite far, so this is a deeply located structure, and for that it is sort of difficult to get a good contrast there. So whenever you have a patient where you're interested in a more superficial and more peripheral lesion, go for ultrasound. When you're interested in a lesion which is more deeply located, abdominal or plexus, lumbosacral or brachial plexus, rather opt for MRI. This is just an example of the power of the tractography and the MR neurography. You can see again here a patient with an amputation of the right arm, and you can see the nerves passing into this nodular structure. So as this is about plexiform neurofibroma, you may automatically think, well, this could be a plexiform neurofibroma, but here I told you that there was an amputation of the arm, and this is an amputation neuroma. Also neuromas can have a sort of similar appearance, T2 very bright lesions, which you can see here, and have some a similarity with the plexiform neurofibroma, but can be clearly distinguished clinically by the history in that case. And you can see in the same case, the reconstruction by tractography, these nerves cannot continue through these neuroma here, as the nerves are basically dissected here. This is another case at 17 years, a boy with sudden or slowly progressing weakness of the left arm. And you can see this is a T1 weighted sequence before and now also after contrast. And you can see before, this is before and this is after. And you can see that the nerve takes up a lot of contrast agent. Nerves usually, except for the spinal ganglia, do not take up contrast agent. They can take up contrast agent either if they are inflamed, like neuritis, or if they are thickened and take up contrast agent, there can be, of course, a tumor behind that. Also, neurofibroma can take up contrast, but in this case, the pattern of contrast enhancement is somewhat peculiar. You see, the entire nerve is affected. It's really going into the axilla here. And this was actually not a neurofibroma again. This was a perineurinoma. Neurioma. I'm showing you this because it's important to keep in mind that not every thickening of a nerve is automatically a plexiform neurofibroma. Not everything which looks like a horse is a horse, so there are also the zebras. And please also think about other potential peripheral nerve tumors or reasons for thickenings of peripheral nerves. Here you have a 7-year-old girl with originally an ATRT tumor of the brain, was radiated in the region also of the spine, and as a result developed this change here to the left brachial plexus. You see a really strong contrast uptake of the nerve, and this was a malignant peripheral nerve sheath tumor. So if you look closely, you see that this contrast uptake goes beyond the nerve into the soft tissue, and this is always a sign that we are not looking at a very benign lesion, and we have to be very careful and think of the possibility of a malignant peripheral nerve sheath tumor in that case. However, I have to tell you that the criteria for malignant peripheral nerve sheath tumors on radiology are not very reliable. So we do not have a lot of very good reliable markers of that. Of course, contrast enhancement is always one of those, but also the inhomogeneous eccentric contrast enhancement affection of the surrounding soft tissue is one marker. But again, be aware that also history is equally important as radiology in those cases. Now, this is another case of a nerve tumor in the region of the median nerve. You can see the thickening of the median nerve here. This would be an ultrasound. The median nerve, it's passing into that tumor. So you can ask yourself the question, is this, and here you can see it on MRI, a neurofibroma or it's a schwannoma. This is an adult person without NF1. If you do tractography in those cases, and I show you these images, in green you can see the ulnar nerve, and in yellow you can see the median nerve. And the median nerve is basically pushed to the side by the tumor, and it's not really passing directly into the tumor. So this is the intraoperative view where you can see that the mainstay of the nerve is basically pushed to the side, and there is this just one part of the nerve is affected by the tumor. And that is rather a example of a schwannoma. So in plexiform neurofibroma, the nerve fibers are more in between the tumors and more basically centrally located, whereas in schwannoma, they are more or less pushed aside and only one fascicle is really affected. This is a direct comparison between two modern technologies. To the left, this is ultrasound with 3D reconstruction of the nerve and the tumor here at the region of the peronal nerve, and on the right side you can see the tractography tool. So both are interesting, both show you different aspects, and I believe also give very nice information to the surgeon later on treating those patients. Here is a 14-year-old NF1 patient, and this is the typical imaging appearance of a plexiform neurofibroma. Again, now you can start asking, are there parts of this plexiform neurofibroma which are more nodular and which are of more concern? Indeed, that's something we also did. And again, here you can try to discriminate typical features of schwannoma and neurofibroma. And I just brought that up because in the literature, you will find the so-called target sign. Target sign means that you have a bright T2 bright tumor, and in the center it's rather dark. So it's like a target. And that was often described to be more frequent in a benign neurofibroma. However, I am personally not a big fan of the target sign. I have seen cases which also with target sign, which also then occurred to be a anup lesion. So this is a case. This is such a case. You see something like a target sign, but then, and again, this is also a matter of definition. What is a target sign truly? And this is a T1 weighted image before and after contrast, and you see there is contrast uptake. It's a large lesion. It's more nodular. It's more than 3 centimeters, and it was painful at that time. So it was resected, and it was described at that time by pathology of a neurofibroma with foci of malignant transformation. So it's really a wolf in sheep's clothing, and we really have to be very careful with attributing imaging diagnosis to these lesions. And here comes the nuclear medicine into and will help us. This is an 18-year-old patient where you see a large nodular lesion, NF1 patient, a large nodular lesion with quite some glucose uptake on this FDG PET CT. And you see 1 year earlier, similar examination this lesion was much, much smaller. So there was a significant growth in size of this plexiform neurofibroma at that time. And we did also an MRI to understand better the location of the tumor. And what we also do is a so-called diffusion sequence. And we also measured the so-called diffusion characteristics. So there were two quantitative imaging parameters you need to keep in mind. One is going with PET and the other is going with DWI. PET, you look at the glucose uptake of the lesion, and if that is surpassing the SUV value of 3.7, and I'm summarizing more or less what is in the literature, you have to be concerned. The same is true for the DWI image. If you measure the so-called apparent diffusion coefficient, and that is smaller than 1, you should be also concerned. So this is the summary. When you should be concerned of a nodular neurofibroma within a plexiform neurofibroma. I would propose to take the cutoff of 3.2 for FDG PET and diffusion ADC value below 1 is also bringing you a quite high sensitivity for malignant transformation in plexiform neurofibroma. FDG PET has slight in the literature in meta-analysis a higher sensitivity in picking those lesions up. MRI seems to have a little bit better specificity than. The combination of both is, I think, the most elegant way to approach that. Now, if you have a patient like this one with an increased FDG uptake and you question, this is a location you can imagine and a surgeon does not want to approach easily. This is in the apex of the lung region. And there is a higher SUV. It's not extremely high, but it's elevated, certainly. And this is how the tumor looks on MRI. So the question is how to approach this lesion. And again, here, a nice imaging, three-dimensional imaging with dedicated nerve sequences or tractography with 3D visualization helps the surgeon to understand where are the intact nerve fibers of the brachial plexus located in relation to the tumor, and is it more advantageous to approach the tumor from anterior or posterior to basically have the minimum damage on the patient. This is another similar case with this nodular lesion in the pelvis on the left side, and again a 3D visualization where the surgeon understood where most of the parts of the lumbosacral plexus were running in relation to the lesion. So basically our surgeons find that very helpful in their decision to treat or not to treat, or to resect or not to resect. As this question is always a question between avoiding malignancy and doing no harm, no additional harm. And finally, you can imagine that as radiologists, you're confronted with the issue of monitoring plexiform neurofibroma. And this is not easy, I have to point out. And it's not trivial. So this is a huge plexiform neurofibroma of the right brachial plexus, as you can see. In such a case, you have to be aware that the children are growing, also their limbs are growing and their bodies are growing. So does also the plexiform neurofibroma. And if you look at the relationship of those plexiform neurofibroma with malignant transformation, they are growing faster than basically the body growth of those children. So whenever a lesion grows faster in relation then the children are growing. These are of particular interest, and whenever particularly, and this is particularly true for younger children. So of course we can measure such a lesion like I did here with 2 calipers through the tumor, but this brings us into the following problem. There are different criteria how to measure a tumor: RECIST criteria, WHO, or volumetrics. In this case, represented here, you would see that with a single diameter measurement, you would end up in a 10% increase of the tumor. Whereas if you do 2 diameters, you would have 26% of increase, and the same tumor measured with 3D volumes, you have a 57% increase of volume. And that is relevant because when you go to the criteria of response criteria, therapy criteria in NF1, you will find that progressive disease is defined by an increase of a target lesion of 20% or more. So according to the RECIST criteria, this tumor would not be progressive, whereas on WHO, it would be progressive, but clearly under volumetrics. And this is truly a problem, as you can see with this case here. Is this tumor now really growing over time? Is it stable, or even some parts decreasing? It's not trivial for a radiologist to tell you this, because first of all, it depends, is always the same part of the tumor imaged, did I cut parts here which were present here and which do not probably go into my volumetric analysis. The next problem is if you segment this tumor, it takes you, if you do it manually, probably 2 to 3 hours. There are now things which can help you with semi-automatic segmentations. You can bring this down to 30 minutes, but it's still 30 minutes. I'm really looking forward to fully automated AI guided volumetrics, which really will bring this time down. And the most promising tool here is really this AI-supported volumetry. Why? Because the computer is always consistent. It's always making an error. It's certainly not perfect, but it's always making the same error, and therefore much better comparable. And this brings me basically to the end of this talk. I hope that you could follow me in the terms that NF1 is a very diverse disease, and radiology in NF1 is not only imaging, it's not only brain imaging, but it's also not only imaging plexiform neurofibroma. It's really touching on different aspects of the body, and that has to be kept in mind. Please keep in mind whenever you're dealing with the patient, suspect to have NF1, and you have a lesion which might, an indicator which may make you think of the disorder. Don't always automatically think of every nerve thickening that this is a neurofibroma. There are other differential diagnoses, and I hope I could also communicate those. High-resolution ultrasound is a very good technique in good hands. Peripheral superficial lesions are very accessible here. Plexus MRI for rather deep lesions. And a very crucial message here is now, if you're looking for malignant transformation, don't only trust pure ultrasound or MRI structural markers. They are often not reliable. Growth is certainly a good indicator, but it's not enough. If you can compare it with a PET or also diffusion MRI, you can increase your likelihood in picking up these lesions and also your confidence in really picking up the malignant lesions. And I think I'm very much looking forward into modern AI-guided systems helping us radiologists to be more consistent in the evaluation of the disease and to tell if something is growing or not. And with that, I'm at the end of my presentation. Thank you for your attention.
Thank you very much, you both of you, for this interesting talks, and I think we learned very much. So this presentations are now open for discussion. Yep.
So I encourage the audience to actually submit questions. We don't have questions yet, but we have a question from Rianne asking both Gregor and Hector if you could comment on what the optimal approach for monitoring plexiforms in children is in terms of clinical follow-up and interval of MRIs, etc. And I would add, since you were mentioning, Hector, the distinct nodular regions, if you had a different protocol that kicks in once one of these lesions has been identified.
Okay. So short answer is please take a look at the Genturi's guideline about how to follow. Even other patients there, we recommend in asymptomatic patients an annual examination and only perform a whole body MRI at the transition to adulthood. But to be honest, I think following up Plexiform Neurofibromas has two main goals. One is to find the symptoms early. You really don't care if the patient has a lot of neurofibromas or only a small one, because we only need to find and to properly diagnose those that are symptomatic. Right now, we only are treating those symptomatic tumors. And the other main reason to perform whole body MRI and to do the annual examination for this patient is to properly diagnose them before they become malignant or before they transform to a NUBS or to MPNSTs. There, you should individualize a lot the follow-up you are performing to the patient. If the patient has already several tumors at 3 years of age, I think you should do it more frequent. But if the patient is totally fine, he's 18 or 20 years old, probably with 3 years examination, it's enough. And regarding your question about the DNLs, as far as I know, there is no protocol recommending annual or twice a year or how often you should do the follow-up of these lesions. But again, according to the data I presented, I suggest that if you find these kind of lesions in a previous, with a previous MRI that it wasn't present, I should consider to follow it up much frequently, at least at 6 months of the previous scan. Maybe if the patient is adult and has 30 years old, it's not necessary to do it so frequent, but at least in adulthood, I would recommend to do it much more frequent than it's recommended in the guidelines.
Thank you. Gregor, do you want to comment on this question at all?
Well, only that I have to say that I should not be able to answer that question because I strongly believe that exactly these questions, apart from sticking to the guidelines, should be basically answered in a board. So if you have the luxury of an NF1 board where different disciplines come together, you can get the input from different sides. So you have your clinician, you have your surgeon, your plastic surgeon, who can also give input. What is the risk of resection? What in weighing this discussion, in weighing basically the risk of resection and avoiding malignancy. So I think the board and interdisciplinary communication is crucial.
Very, very wise advice. I also have a question regarding pain. From your presentation, Hector, it's clear that pain is an issue in most plexiform neurofibroma patients. What isn't clear to me, I wanted to ask two things, is that are you able as a doctor to pharmacologically treat this pain successfully? And also, what isn't clear to me is this pain in the tumor itself, or in the surrounding area of it? If is the tumor itself painful, or is it more generalized and a more diffuse kind of pain?
That's a tricky question, Marco. Plexiform neurofibromas are composed of different cell types. It's also obviously the Schwann cell precursor tumor cell, but it also has the mast cells, the fibroblasts, the microenvironment that makes that the symptoms of these tumors can change a lot from one day to another. Sometimes they are complaining a lot of it's very painful, especially if you push that or if you pressure that, but sometimes they don't. And that's why what explains the different behavior in the same patient during the several periods of time. But that's why we really don't know what's the reason of the pain. That's something that's already seen when treating these patients with MEK inhibitor, for example, that sometimes the tumor hasn't changed, and in 2 weeks, the pain has completely been gone. So the tumor is there. So why it's not painful? Probably there are something in the microenvironment that makes these tumors some painful, and probably also the schwannomas in schwannomatosis. It's something we really don't know yet.
So are you aware of any studies that have been done, at a purely biological level to try to understand pain mechanisms in NF1 plexiform?
No, as long as I...
in animal models, or,
There are a lot of trials, with several medications just to check on that, but none of them are performing biopsy of the tumor just to check what's happening there. There are a lot of mice models and checking the cells, but not really on the pain by itself. And regarding the question of how we treat the pain on the tumors, it depends a lot on the patient and.
But are you able to manage it with with pain treatments available?
Yeah.
Or are there cases when it becomes just a chronic pain that is not completely manageable?
Yeah. Usually with GABAergic medications, the pain can be controlled, but in my experience, if the patient gets pain when he's young, usually this pain gets worse and worse, and you will never control the pain well, as long as you make the GABAergic or morphine or radioablation. There's a lot of treatments you can offer to the patients. But we have right now the MEK inhibitors. Usually the pain is really not an issue anymore for this patient that are not responding well to the usual treatments for pain.
Thank you. And I actually have another question for Gregor, because you were mentioning that the ideal combination when there's a when there's the suspicion of a malignant transformation is to do both PET and both CT and PET MRI. I wondered if you could comment on what the impact of these technologies are on the children, and the fact that you are performing these tests on children.
Well, we have in Vienna the luxury of having available a PET MRI hybrid system. So whenever it's possible, we certainly will prefer to go for the hybrid system. Of course, in a clinical practice, this is not so easy. We need sedation, we need an anesthesiologist, because these children are young, particularly in the younger ones. In the older ones, it's easier for CT, PET CT and PET MRI. And however, I think all hybrid technologies per se are very, very helpful in the disorder, because locating the FDG uptake accurately to a structural lesion is key here. However, when you have the luxury, ideally it would be PET MRI. What I would like to add is often that if you do whole body imaging, you have to be aware that the quality of a target lesion, the depiction of a target lesion, is often not sufficient to meet a surgical decision. So it occurs that in our setting, sometimes the surgeon would say, okay, I'm interested in this lesion, but I would like to have a more detailed anatomical visualization, and we will do a dedicated MRI for a certain lesion just in preoperative setting.
Well, thank you both very much, and Rianne, for being here as well. We are way past our time, and thank you to the audience for being present. Although I'm very disappointed that we didn't get any questions from the audience at all, but it happens. So unless there are any other things that you'd like to comment on, or further comment on your lectures, Hector and Gregor. Well, then I really thank everyone for being here with us today. So as a reminder to the audience and those who will actually see this on the YouTube channel, this webinar has been recorded, is being recorded, and will be posted on the YouTube channel as soon as humanly feasible. And this is just the first part of a two-part series on focusing on plexiform neurofibromas. The second part will focus on treatment and choices that the multidisciplinary teams have to face when deciding if and when to treat a patient. So the second part is being planned at the moment, and it will be advertised as soon as we have set a date, which will be in the early spring anyway. I thank you all, and I hope to see you soon again for our master classes. Thank you. Bye-bye.